let's get started. We are starting a new unit today. We're starting module 4. We're going to spend the next couple of lectures talking about adverse reactions to the transfusion. So if you guys remember, the ultimate goal of blood bank is to provide products that are safe for transfusion to replace whatever our patient is lacking. Okay, for oxygen carrying capabilities, then we would give them red cells. If they needed a coagulation factor replacement, then we could give them FFP or cryo. All right, so the ultimate goal is to provide safe transfusions. There are known adverse reactions from transfusions. Of that includes infectious disease. Okay, so you are at a risk for infectious disease when you receive a blood product. However, testing has come a long way, and then not today, maybe tomorrow, we will talk about the specific infectious disease testing. So that is considered an adverse reaction, all right? If you obtain an infectious disease from a transfusion, that is a adverse reaction. All right, so what we're gonna talk about in this lecture though is a more immediate adverse reaction, transfusion reaction. And most transfusion reactions, severe ones anyway, are going to occur as soon as that transfusion starts or during that transfusion, okay? So the most common ones we will see in blood bank are going to be obvious, either at the start of that transfusion, during, or immediately after, okay? And so that's why, you guys, when we talked about monitoring the patient vitals, that's why those vitals are taken before transfusion, 15 minutes after starting that transfusion, and then 30-minute increments the whole time during that transfusion. We are trying to detect symptoms of these transfusion reactions, okay? And so that's what we're going to talk about. What are the symptoms of the different type of reactions, and then what type of reactions are there, okay? And so what is an adverse transfusion reaction? This is how AABB and the FDA describes side effects from receiving the transfusion. And it's just an undesirable response or an effect in a patient temporarily associated with the administration of a blood product, okay? So it's stated that about 10% of transfusions have a negative effect. So we could have a successful transfusion, no adverse reactions, no transfusion reactions, no transmission of infectious disease. That was a 90% of the time, that's what's gonna happen, all right? 10% of the time, it will have a negative impact on your patient, okay? And there's huge movement right now in blood product management, transfusing. A lot of hospitals, like I mentioned before, have lowered that hemoglobin threshold. So if your patient has a 10 gram per deciliter hemoglobin, well, they are not a qualified recipient of red cells, right? Because their hemoglobin is sufficient. They should have sufficient oxygen carrying capabilities. Red cell transfusion is not very appropriate for them, right? And that's just to reduce the exposure, number one, for alloimmunization, because that is actually an adverse reaction as well if we cause our patients to build antibodies, and we'll talk about that in the next lecture. And then the risk for infectious disease and the risk for having a transfusion reaction, okay? And like I mentioned, most serious reactions are going to occur during or immediately following that transfusion. And you guys never ever forget, you might see this on your ASCP Board of Certification. Clerical errors is the #1 cause for transfusion reactions in blood bank and ultimately patient death, okay? If you give a patient the wrong type of ABO and blood bank does an investigation, most oftentimes the cause is some type of clerical error, right? The patient was misidentified, right? That might be a pre-analytical error. The sample was tested but recorded on the wrong patient, right? That is also a clerical error. The wrong unit was cross-matched on a patient. That all goes back to testing error, clerical error, okay? And this just gives you some risk of transfusion. So HIV, you have less than 1 to 2,135,000 risk of obtaining HIV from transfusion. Hepatitis B, notice that hepatitis B has the highest risk, right? So most oftentimes hepatitis B is the #1 transfused infectious disease. All right, so here are your most common transfusion complications, and we're going to talk about each of these. Number one is your trolley. It is actually associated with the highest morbidity rate in blood bank now. It's the number one reason for transfusion reactions that we are seeing in blood bank right now. So it's a transfusion-related acute lung injury. That is your trolley, okay? We're going to talk about why that happens. Also, your transfusion-associated circulatory overload, all right? That's when whole blood used to be, this used to cause a whole problem when whole blood was the most common product. Remember, if your patient needs oxygen carrying capabilities, they don't really need the plasma, right? So if you give them plasma, that could overload their circulation system, right? Could cause them to have lung failure, and we're going to talk about the symptoms of that, all right? And there's two specific populations that TACO is very common in, and we're going to talk about that. Hemolytic transfusions due to non-ABO, all right? So this would be a febrile non-hemolytic, or sorry, this would be a hemolytic transfusion that is not related to ABO. So this would be like those HLA antibodies that we talked about. They can cause a hemolytic transfusion reaction. Versus ABO-related hemolytic transfusion reaction, that's when your patient gets the wrong type of ABO, okay? And microbial infections, and then also anaphylactic reactions as well. Oftentimes in blood bank will recommend that we pre-medicate our patients. So to prevent hemolytic febrile transfusion reactions, you could give them acetaminophen. You could pre-treat them with that. Or to prevent anaphylactic allergic reactions, you could give them Benadryl to pre-medicate. However, that's not a common practice. So a lot of times when nursing staff calls the blood bank, and they say, hey, we have a transfusion reaction, my patient has a fever, we're like, well, did you pre-medicate them? They're gonna be like, no. And then blood bank has to do a complete workup, okay? So oftentimes some of these reactions, if your patient is known to have a reaction, we can pre-medicate them with either Tylenol or Benadryl to alleviate some of the symptoms, especially if it's just an allergic reaction, okay? All right, so here are some of the symptoms of a reaction. If your patient develops a fever, so if their fever spikes greater than 1 degree Celsius, okay, that is considered a transfusion reaction. Or if their temperature starts to increase greater than 98.6 degrees Fahrenheit. Or I guess it should be 99. If you're, 98.6, if they start out at 98.6, they're good to go, all right, that's normal. But then if they start getting above 99, that's when you might suspect a transfusion reaction. Chills and rigors, all right, that's another symptom. Your patient might start complaining that they're getting very cold. Respiratory distress, all right, so if anytime the nurse calls and says, my patient's having a hard time breathing, they started coughing or wheezing, tell them to immediately stop the transfusion, okay? Blood pressure change, if their blood pressure spikes or gets lowered, that could indicate some type of transfusion reaction. And any type of pain. If you give your patient the wrong type of ABO, they are going to immediately start complaining of back flank pain right here, all right? So that's the number one indicator of a wrong ABO, okay? Some people might even complain of chest pain, especially during a trolley, all right, because the lungs are gonna become, fluid could start infiltrating the lungs, okay? They might start complaining of that too, as well as having a hard time breathing. Jaundice and hemoglobinuria, you will probably see that in a delayed transfusion reaction. Remember we talked about the KID antibodies, how the titer drops to undetectable levels, and then if we give them a KID positive unit, then that titer is going to spike, initiate a amnestic immune response, secondary immune response. The patient could present about 5 to 7 days later with symptoms of jaundice and decreased hemoglobin levels. Nausea or vomiting, any type of abnormal bleeding, nosebleeds, anything like that during the transfusion, that could be considered a reaction. And then your urine output. So if your patient stops having any urine output, again, that would probably be a more delayed transfusion reaction. Okay, so your transfusion reactions can be divided into two types of categories. Is it a acute, meaning that it happened instantly, all right? Or is it delayed, right? And so AABB kind of divides this acute versus delayed based on, did it happen within 24 hours of that transfusion, right? That's an acute reaction. Did it occur greater than 24 hours of that transfusion? That's more of a delayed, okay? And then, was it immune mediated or was it non-immune, all right? So immune mediated would be any type of hemolytic given, and really you think about, if you're given red cells, you think about the patient building an antibody or a patient's already existing antibody attack those donor cells, causing a transfusion reaction. An allergic reaction would be a immune. Trolley is an immune. Non-immune is if that unit was septic, all right, because then we caused that patient to be bacterial contaminated. Circulatory overload, and then if that unit was hemolyzed, okay, that's non-immune. Immune related for a delayed is if we alloimmunize that patient, like I mentioned, so they're going to build an antibody. And then non-immune mediated, so one side effect also is among our sickle cell patients and our alpha thalassemia, or really any thalassemia major patients that are transfusion dependent, they have iron overload as a side effect. And so hemosiderosis is a side effect for those. And then citrate toxicity we'll talk about as well. All right, so your common types of transfusion, and temperature is a huge concern for blood bank, all right? So the number one thing is we want to look at, did the patient spike a fever, okay? If the patient spiked a fever, a couple of things you want to think about. If your patient received the wrong type of ABO, that will cause them to spike a fever because of the immune response that's going to happen. If that unit was contaminated and the patient was exposed to some bacteria, that could cause a spike in their temperature. And if there's any HLA antibodies involved, that would cause a spike in the temperature as well. So we always classify our transfusions as hemolytic febrile, non-hemolytic febrile, all right? And so we're going to talk about those. And then an allergic reaction, the most common symptoms, the patient's going to complain of itching, or they might even have a rash start breaking out on their skin as well. And then, of course, alloimmunization. These patients have an increased risk of building an antibody when they're exposed to foreign donor cells. Less common, circulatory overload. Symptoms of that, headache, their blood pressure is going to spike, and then delayed hemolytic transfusion reactions. Delayed transfusion reactions are not life-threatening, all right? It's going to be about 5 to 7 days, can be even up to 28 days later. Your patient is going to present with symptoms of anemia, hemoglobinuria, and jaundice, okay? And that's just because the antibody is attaching to the red cells and their spleen is taking out those red cells, and that's what's causing their anemia. Okay. Unusual types of transfusions. Immediate hemolytic transfusion reactions. This would be if you gave the wrong type of ABO. It does not happen, all right, very often in blood bank. Okay, there are several safety mechanisms in place before that patient transfusion is started. Okay. If you think about an allergic reaction, and we're going to talk about this, the patient could have a minor allergic reaction, right, due to the IgE, activation of the mast cells, release of those histamines. Okay, that's going to be a minor allergic reaction. If your patient is IgA deficient and they are exposed to some type of plasma protein of a IgA patient, if your patient is IgA deficient, they could potentially have built anti-IgA, so they could attack that donor product. That could cause a more serious allergic reaction, and that would be anaphylactic, all right? And we're going to talk about the difference between an allergic reaction and an anaphylactic. Bacterial contamination, iron overload, and then graft versus host, okay? Remember, graft versus host disease is also an adverse effect of transfusion. And remember, there are mechanisms in blood bank to prevent all of these transfusion reactions, okay? However, errors do occur. Number one, patient identification, sample error. Wrong blood was issued to the wrong patient. Some type of transcription error, some type of administrative error, technical error, storage error in the products. Okay, maybe your unit of red cells sat out at room temperature greater than 30 minutes, all right? Providing the perfect environment for bacteria. Okay, and then we're going to talk about some specific bacteria that can survive at 4 degrees. And then platelets, you know what, kept at room temperature. Platelets are the #1 product associated with bacterial contamination, and it's just because they're kept at room temperature. All right, so let's talk about our acute transfusions. Remember, it's acute because it occurs immediately, all right? And AABB describes that immediately as within 24 hours of that transfusion. So you could notice symptoms as soon as that transfusion starts. You might not notice it until 6 hours post-transfusion. Okay, but if it's within that 24 hours range, blood bank will consider that an acute transfusion reaction. And those causes could be allergic, all right, meaning your patient complaining of hives or itching. Febrile, all right, meaning that your patient developed a fever. Circulatory problems, hemolytic, bacterial contamination, okay? So this is just what happens in an acute immune-mediated transfusion reaction. And AHTR, you guys probably need to get familiar with these abbreviations. That is an acute hemolytic transfusion reaction, okay? So what's going to happen is your patient is exposed to some donor red cells, all right? Obviously, probably not antigen negative for their corresponding antibody. So that patient's antibody is going to attach to those cells in vivo. Depending on what type of antibody, if it's ABO or another IgM antibody who are capable of activating complement, then that antibody is going to attach to the red cells. Complement is going to be activated. And then your complement cascade, once C9 is incorporated on that red cell membrane, cell lysis will occur. And you guys remember the activation of complement. It can initiate process of phagocytosis, release of cytokines, which can activate your coagulation system, right? So your patient could go into DIC, and then ultimately that could lead to renal failure. The patient could go into shock and then ultimately die. This is what happens in your wrong ABO transfusion, okay? All right, so an allergic transfusion, I want you guys to understand in an allergic transfusion, we're not dealing with any type of fever, okay? So your patient's temperature should remain the same. And your symptoms can vary from mild to severe depending on what the cause is, all right? So if you're mild, your symptoms are just going to be urticaria, all right? So your patient might develop some type of rash or hives, okay? And they're going to complain of itching. Usually they're going to develop the rash like in the bend of your elbow. Some of you guys might have had an allergic reaction before. It's the same. Usually you'll develop the rash in the bend of your elbows, on your abdomen, right here, behind your knees. All right, that's where the typical rash is going to form. And then the patients are going to start itching. They'll start scratching themselves. So usually you'll see the mild allergic reaction, like I mentioned, if IgE is involved, okay? So these patients, the transfusion will cause an allergic reaction in the patient. If it's mild, it's usually that IgE has initiated the mast cells, going to release histamine. It's going to cause all of those normal symptoms that you see in an allergic reaction. However, if your patient is IgA deficient, okay, and remember, if you are deficient, you can build antibodies. So if you are IgA deficient and you have anti-IgA and you are exposed to red cells, and remember, in red cells, there's a minute amount of plasma that remains in those red cells, very small, okay? But even a very small amount, if you are IgA deficient, can initiate a response, okay? Or if you are exposed to a FFP unit, okay, where you're getting strictly plasma, okay? So typically that's when we'll see these severe anaphylactic responses, right? So do you guys remember how we can prevent, if your patient is known to be IgA deficient, how we can prevent anaphylactic reactions in those patients? All right, so if you're given red cells or platelets, we can wash those products to remove any of the remaining plasma that is in those products. What if your patient needs plasma? Can't wash plasma, all right, because you would just wash the plasma away. We could call in IgA deficient donors, okay? They could donate their plasma for a IgA deficient recipient, all right? All right, so a lot of times, as soon as the symptoms develop in the patient, the nurse is going to call you. And it's very important. The first thing you need to tell them is to stop the transfusion, okay? It's the first thing you need to tell them. Number two, you ask them what type of symptoms your patient is having. If it's just mild allergic symptoms, we will suggest that they give the patient Benadryl and continue the transfusion, all right? Now, obviously, if it's a severe anaphylactic and their airway is blocked off and they're not able to breathe, then immediately stop the transfusion, give epinephrine, and everything like that, all right? So it just depends on what your symptoms are. But if it's just a mild allergic reaction, we will tell them to pre-medicate with Benadryl, okay? Your textbook actually mentions that for mild allergic reactions, there is no need for blood bank to perform a workup. We do not need to do a transfusion reaction workup on an allergic reaction. Number one, we're going to do a clerical error check. We're going to request a post sample. When we do our transfusion reaction workup and we test our post sample, everything's going to be the same, all right? We're not going to be able to detect anything about an allergic reaction in our patient. Okay. Now, if it's a severe, then and the clinicians expect an IgA deficiency, then that patient needs to be IgA tested. Okay. So if your patient is having severe reactions, and severe reactions would be like their throat starts swelling, maybe they have some edema, anything like that, then that is indicating of an anaphylactic shock rather than just having hives. Okay, that's a mild reaction. Give them some Benadryl, all right? Yes? Does blood bank get in trouble when there's reactions? So blood bank will initiate an investigation. That's our transfusion reaction workup. In the event we do a transfusion reaction workup and we find out the patient was transfused the wrong type of ABO. And remember, I told you guys that your tech initials, tech ID is attached to all of the work that you do. So if the wrong ABO ended up being transfused, then it falls back onto the testing tech and it falls back onto the issuing tech. And they are going to figure out exactly how that wrong ABO was transfused. Now, depending on your hospital's policy, will you get fired? Probably not. You might have to go through retraining to prove your competency. And then that, of course, is definitely an FDA reportable error. So it will get reported. So it just depends. An investigation will happen. Yeah.
What if
Usually if you are involved in blood bank testing and you are involved in the wrong ABO being issued, it will go in your personnel file. And so that FDA write-up will also go in that file as well. So.
What if it's for IgA deficient patients?
No, that is not your fault. So if it ends up, and oftentimes we don't know beforehand if our patient is IgA deficient. Usually what's going to happen is these patients are transfused, they have a severe reaction, investigation incurs, and they decide that they determine the patient is IgA deficient. That will go on that patient's record, and from that point on, they should only receive washed products or IgA deficient plasma. So in that instance, it's nobody's fault. It was just an adverse reaction the patient had. So that's what most often happens in blood bank. It's just an adverse reaction. It was really hard to be detected beforehand. Now, unless the patient had an antibody and blood bank missed it in the initial testing, that's why we do our post workup to make sure nothing was missed, and then we can figure out where the error occurred. Otherwise, the patient had a reaction and we find out after that they had a anti-JKA that was identified 10 years ago at another facility, and now we've got a secondary transfusion reaction, a secondary immune response in them. That's kind of how it works. We try to do everything we can to prevent it, but sometimes we don't know enough, and then we have to investigate it after. Does that make sense? Will you get in trouble? The worst thing that will probably happen is you have an FDA reportable error.
So if you do your testing and it comes up JKA negative, and then he gets a transfusion reaction, and it turns out that in his post he was JKA positive, then
well,
he had an antibody.
Your language there, so beforehand we wouldn't know that he was JKA negative. What was going to happen is that, and that's not anybody's fault, it's just the way the human immune response works, that he hasn't been exposed in so long, his titer drops to undetectable levels, right? So on initial testing, our IAT was negative, and if we don't have a history on him, we have no way of knowing, right? And so then we don't know, so we're gonna give him cross-match compatible units because that titer is real low, it's not reacting, so according to blood bank, this unit is safe for him, but that antibody that's in his circulation is going to be activated, and then anywhere from 5 to 7, 10, 15, 20 days later, he's going to present with that delayed transfusion reaction, symptoms of anemia. Again, that's not life-threatening. So then blood bank would do our workup and we would identify that antibody because his titer is now detectable. Does that make sense to everybody? Now, Arkansas is not a licensing state, so I have never dealt with if you give somebody the wrong ABO and that's reported to your licensing institution or body. I don't think they can pull your license, but like I said, I've never been in a licensed state. So, but that would be what happened for like nurses that continue to make errors. Or anything, physicians, they can pull their license. So.
How many FDA reportable errors do you have?
I don't know if there's any documentation on that. It would probably really be up to your employer. Like if you consistently are making errors, then they might say blood bank is not the department for you. They might move you to another area. Because blood bank is so highly regulated, and then they are inspected by the FDA, so they will definitely, when they are inspecting your lab, they will look at your reportable errors and your history, and if it's linked to like one technologist, they're gonna say there's an issue there. They're gonna wanna look at your training, look at your documented annual competencies, and they might suggest replacement. So. I personally don't know of any cases like that. So that's why it is just a good habit to double and triple check everything. Now, when a transfusion reaction does pop up in blood bank and we start doing our investigation and you were the tech involved on the initial testing, it is a little you know, you're like, oh no, what happened? Or like, did I miss something? Or, you know, but usually what happens is it's a hemolytic non-febrile transfusion. That's what we most commonly see in blood bank. And is it due to HLA antibodies? Was it bacterial contamination? So that's usually what happens. So, in all of my experience in my years of blood bank, we never had a wrong ABO given to the patient. So.
What would happen if it was it was determined to be a bacterial?
So what's going to happen during the transfusion, if that unit is bacterial contaminated, your patient's fever is going to spike. And any time a transfusion reaction is involved in a fever spike, the nursing staff has to send that unit back to blood bank. We will forward that unit to micro, and they're going to culture it and to see if it had any growth in it. And if it did, then usually that recipient is put on antibiotics. They treat the organism, and that patient recovers fine. So here's some symptoms of your anaphylactic reactions. And remember, when we say anaphylactic, this is a severe allergic reaction. Okay, they're going to have wheezing. They might develop a cough, a non-productive cough. They could have vomiting, again, respiratory distress, because if you guys have ever had a severe allergic reaction, you know that your throat can become very swollen. Your airways could be blocked. And so if a nurse ever calls you with that, tell them to immediately stop the transfusion, and they need to treat for anaphylactic shock, give epinephrine. Yeah, and so your response, immediately stop the transfusion, give steroids or epinephrine. Blood bank is going to initiate a workup because it is considered a severe reaction. Most oftentimes, all of our pre-testing that was done, when we reconfirm that, because we're going to repeat, if we have the initial specimen, which we do if it's an allergic reaction, then we're going to repeat the testing that was performed, all right, to make sure nothing was missed. And then we're also going to get a specimen after that transfusion. We will do our post specimen. If it's an allergic anaphylactic reaction, all of that post testing is going to look exactly like our pre-testing. Okay, our DAT is not going to be positive. Our IAT, if it was negative before, will remain negative. If the patient already had an antibody, it will still be there as well. Okay. And then if it's proven that your patient is IgA, we will give them washed products or IgA deficient plasma. Okay. I took this chart from your textbook, and it just differentiates the difference between a mild allergic reaction and then anaphylactic reaction. Notice in both of these, part of a transfusion reaction workup is performing a DAT. Okay, on that post sample, we will do a DAT. In the instance that we talked about, the delayed transfusion reaction, and that patient's anti-KID is now coating the cells, your DAT is going to be positive. All right, so anytime you have a wrong ABO transfused or a delayed transfusion due to an antibody, then your DAT is going to be positive. Notice in your allergic reaction, your DAT is negative, okay? So that's one way blood bank will differentiate what type of transfusion reaction occurred. Patient symptoms, very important. And then number two, what was our DAT? Okay, if your DAT is negative, it's definitely it could be immune, but it's non-hemolytic, all right? And notice that there's no visible hemolysis. So that's something else we'll look for in our post sample. Once we spin that sample down, if there's hemolysis, that could indicate a severe transfusion reaction occurred. All right, but if there's not any hemolysis, that indicates, you know, it's probably not, it's not a hemolytic transfusion for sure. All right. Notice in the management, there's a little bit difference too. In a mild urticaria reaction, transfusion is interrupted and Benadryl is given and some type of antihistamine is given, all right, versus the anaphylactic, that transfusion is terminated, all right? Stop it, don't go any further. Okay, so let's talk about our febrile non-hemolytic transfusion reaction. So this is a febrile transfusion reaction, so meaning that your fever has spiked, either 1 to 2 degrees above your starting temperature, okay? Patient's gonna develop that fever, so they're also gonna complain of chills. They might even complain of being flushed, but maybe their face starts feeling warm. Mild discomfort, but usually not any serious symptoms associated with it, okay? This is a febrile non-hemolytic, all right? What happens in febrile non-hemolytic, you need to keep in your mind 2 different things. Number 1, bacteria, was that unit contaminated? And number 2, was it HLA involved? All right, so we typically, this used to be a common occurrence in blood bank. Right, we used to see febrile non-hemolytic transfusion reactions all the time. However, you guys remember one attribute to products that has been implemented to help reduce febrile non-hemolytic transfusions? Leukoreduced. All right, so with the introduction of leukoreduced products, these febrile non-hemolytic transfusion reactions has drastically decreased. Okay, and that's just because leukoreduction reduces the number of white cells. Most of these febrile non-hemolytic transfusion reactions occurred because of HLA antibodies. So your patient would have an antibody to the HLA antigen present on those white cells. That's what would cause your patient to spike a fever. Those HLA antibodies initiate the immune response, your patient spikes a fever, okay? And that's why we said oftentimes blood bank will suggest pre-medication with Tylenol to prevent this fever. Okay, those HLA antibodies are not life-threatening, all right? You will also see that in platelets too. If you are transfusion platelets, those platelets have antigen sites on them as well. Patients that receive multiple platelet transfusions, such as our leukemic patients that receive platelet transfusions a lot, they can develop platelet antibodies. And if you have platelet antibodies in our transfused platelets, then that could also cause a febrile non-hemolytic transfusion reaction. Keep in mind, it's due to antibodies, okay? So this is still considered an immune transfusion reaction, okay? So what do you do if your nurse calls and says, my patient has spiked a fever? Number 1, we're gonna stop the transfusion. Anytime there's a fever involved, that warrants an investigation, all right? You could give them some Tylenol, all right, to help treat that fever. And then in our investigation, we will check for clerical errors. We will do our post-specimen hemolysis visual check. And then we will also send that bag to micro for culture to see if it was contaminated. If that culture is negative, so if the gram stain is negative and then the plates end up being no growth as well, then that might suspect some type of HLA antibody involvement, okay, or platelet antibody involvement. If your patient is determined that they have a platelet antibody or a HLA antibody, that signifies that your patient needs special attributes, okay? So especially if they're receiving multiple platelets. You guys remember that if a patient has a platelet antibody or an HLA antibody and they receive single donor platelet pheresis, they could be refractory. You guys remember that? So those platelets are actually going to be destroyed rather than helping increase their platelet count. One way that we can do that in blood bank is we can give HLA matched platelets if they have an HLA antibody, or here at UAMS, we can even cross match platelets, right? So we could take patient plasma, mix it with those platelets and see if there's any agglutination, right? If there's not agglutination, then those are cross match compatible platelets. Okay. Not all hospital facilities perform that, right? So if you're at a smaller institution, you will have to order those products. right? You will have to order HLA matched products. You'll have to order, you'll have to send plasma to the reference laboratory, and they will give you cross-match compatible platelets, all right? Sarah has a question. You culture the temperature of administration or phases of testing? So anytime your patient develops a fever, that would be when you send the unit for culture. Now in blood bank, we will repeat our testing. We're going to repeat our IAT. We're going to repeat the ABO and make sure everything remains the same and like nothing was missed, no clerical errors occurred. Does that make sense? I took this chart from your textbook, kind of just further describes characteristics of a febrile non-hemolytic transfusion reaction. Notice the key word in that title, non-hemolytic, all right? So there's going to be no visible hemolysis and our DAT is negative, all right? So you guys need to be aware in all of these different situations what your DAT is going to be. Blood bank relies heavily on DAT results when doing transfusion reaction workups, okay? So if your patient spikes a fever, but the DAT is negative, we will call that a febrile non-hemolytic suspect bacteria or HLA antibodies, all right? And again, these most oftentimes, if it's due to HLA antibodies, acetaminophen pretreatment. And if it happens, they can manage that with acetaminophen, Tylenol, some type of fever reducer, okay? And a way to prevent that, all right, so if you determine your patient has HLA antibodies, we will give them leuko-reduced products, okay? If it's platelets, we'll probably give them HLA matched or cross-matched, all right? A lot of students want to say in order to prevent, and you guys need to know this for your exam today too, in order to prevent HLA antibody reactions, we will give irradiated products, all right? What does irradiation prevent? Graft versus host. It inactivates those mature T lymphocytes, all right, from proliferating in the donor and attacking the donor tissue, the recipient tissue, okay? So it's your donor T lymphocytes initiating the attack in graft versus host. Okay? So don't get leuko-reduced and irradiated confused. Okay, now let's talk about hemolytic transfusion reactions. This is the most severe, all right? And it will cause the most serious reactions. This is what will happen if you give the wrong type of ABO. Like we mentioned earlier, can cause your patient to go into DIC, can cause renal failure, could cause shock, and ultimately lead to death. And what your symptoms are going to include. Number one, your patient's going to spike a fever. They're going to complain of chills. They might complain of chest pain. Their blood pressure might drop. They're going to have a hard time breathing. They're going to appear very anxious because, of course, you're having a hard time breathing. Okay, you're going to be very anxious about that. Patient could develop nausea, vomiting, and then definitely going to have hemoglobinuria. So anytime blood bank suspects a hemolytic transfusion reaction, we will always request a urine be sent to the lab as well. That is how we will detect the hemoglobinuria, okay? So that would be a post-transfusion urine sample, okay? We're looking for any free intact cells or hemoglobin, all right? It could be developed that your hemolysis is occurring at such a high rate or severe case, your patient doesn't even have any urine output. If that patient's in kidney failure, all right, it could be that they don't have any urine output at all. And then again, number one, stop the transfusion, but maintain that IV access, all right? They're gonna need support fluids. Number one, probably cold blue is gonna be initiated on them. And then the rapid response team will be in that room, okay? So if your patient has an hemolytic transfusion reaction, establishing blood pressure is a huge concern for them, all right, because their blood pressure has dropped, hypotension, renal function, all right, they could go into renal failure, Coagulation, all right, they're going to go into DIC, so we want to monitor that, check for that. Blood bank is going to check for any clerical errors. What happened? Why is that patient having a hemolytic transfusion reaction? And then blood bank is going to perform the pre and post transfusion testing, okay, including that DAT. So what are you going to see? What's our DAT going to be? If your patient received the wrong type of ABO, and it depends on the timing of when that sample is drawn. If it's a severe hemolytic transfusion, red cell hemolysis is occurring rapidly, very fast. If you do get a sample and it has 2 cell populations, then that indicates that maybe you had an old patient that was transfused A cells, okay? So then you have the donor, you have the recipient cells, the O cells with those donor A cells. However, remember, ABO antibodies are going to attack those cells. Hemolysis is going to be very immediate. You might not see that mixed field agglutination depending on how fast this is happening and the timing of that sample collection. Okay, does that make sense to everybody? And then even if you suspect the wrong ABO, your DAT may be negative, all right, if there's any delay in drawing that specimen. So if they don't draw that specimen right away, we might not see the 2 cell populations there, and then there might not be anything coding the remaining cells, so that DAT would be negative. Okay, that's why if a nurse calls you, tell them to immediately stop the transfusion, send a post sample right away, right, no delay, okay? However, I would bet as soon as they call it and they collect a sample and your patient was given the wrong ABO, that DAT is going to be positive, all right? Now, unless it was like 4 to 6 hours later, but they're not going to wait that long. They're going to send it to you ASAP because they want to know too what's going on with the patient. All right, so here's what we do. Here's what it looks like in blood bank. We are going to repeat the ABO and the RH on the pre-sample, all right, so the sample that we initially did our testing on. And remember, we keep those in blood bank, so we still have it in our refrigerator. So we're going to pull it out and repeat the testing. We're going to check for any clerical errors. That's the #1 thing that we're going to look for, all right, in our investigation. Make sure the initial sample was labeled appropriately. Make sure it matches the requisition. Make sure it matches the current patient that's having a transfusion reaction, okay? Everything has to match. And then that post sample, once we get it, we are also going to do, of course, our ABO RH. We're going to do our IAT. We'll repeat it on the pre-sample, perform it on the post-sample. I like to say whatever test was performed on the pre-sample, you do it on the post-sample. You treat those samples the same, okay? And then you will repeat those cross matches, right? Make sure that unit was compatible. And if you did have a wrong ABO, how was that cross match 4+ at initial spin missed, okay? Now there's some situations, let's say your patient qualified for electronic cross match, okay, which means they already have 2 established ABOs on file. So how did the wrong ABO get issued to that patient? It must have been during the issuing process or at the patient bedside, okay? You always have to be careful if there's 2 patients in the same room. I don't know if you guys know this or not, but pay attention to it. Nurses often identify patients by their room number. Okay, so if you're F16, they say, oh, the patient's in F16 needs a transfusion. Okay, they will call you and say, oh, F16, I'm ready for his blood. I don't know who that is. Okay, so that's why usually 2 unique identifiers. So there's a lot of room where errors can occur. All right. We will check for hemolysis. Again, when we get our sample and spin it down, is there any visible hemolysis in that patient's plasma? And also, if they suspect a hemolytic transfusion, it's very important they send urine to the lab as well. Is there any hemolysis present in that urine? If it's severe, we also want to look for symptoms or findings typical that you see in hemolytic anemias, right? That haptoglobin is going to be decreased, the LD and bilirubin is going to be increased, and CBC and PT and PTT, right? Because if it's a serious hemolytic transfusion reaction, and your patient might even go into DIC, we need these coagulation testing, Okay, what's your PT and PTT going to be if your patient's in DIC? It's going to be increased, all right? And your fibrinogen is going to be decreased, all right? And then the D-dimer is going to be elevated, all right? All right, so hemolytic transfusion reaction is the worst symptoms and it's the most severe, okay? If your patient has a hemolytic transfusion reaction, more than likely that DAT is going to be positive, all right? So if the wrong ABO was given or your patient had another antibody that causes hemolytic transfusion reaction, that DAT is going to be positive, all right? However, well, never mind, that wouldn't be. Okay. What about some non-immune hemolytic transfusions? Okay, so a hemolytic immune transfusion reaction, wrong ABO, or the patient had a antibody that caused the another antibody that caused the hemolysis. Some other non-immune hemolysis symptoms, if your patient has a high fever, that's why we take that patient's fever prior to starting that transfusion. Or if your patient is at a really low temperature, right? That could cause some reactions in the transfusion as well. Oftentimes, and it is known for patients that have like a mechanical valve pump, so if they have some type of artificial heart in place too, as the red cells go through the heart, lysis can occur as the cells pass through there as well. So that's a known side effect. All right, so bacterial contaminated blood. This is very serious, okay? And if not treated, it could be fatal. So as soon as symptoms start occurring, then we need to find out, number one, is it contaminated? And number two, which organism is it? That's why before you guys issue any products in blood bank, you always do a visible inspection. Okay, so I'm gonna tell you some clues and it's up to you. You have the authority. If this unit looks funny to you, maybe it's very turbid, maybe it has little micro clumps in it, anything like that, you can discard that unit, all right? Say that I do not want to give that to any patient, right? You have that capability, you have that authority, okay? So that's why visible check is so important as well. Now there's a lot of mechanisms in place during the collection process, and in blood bank, we try to keep that unit closed at all times, store at appropriate temperatures, to prevent bacterial contamination, all right? But remember, platelets are the #1 culprit in bacterial contamination. And even for red cells, all right, that's the perfect environment. Everything they need to grow is in that unit, all right? It's the very best medium for those bacteria, all right? And so there are some organisms, Yersinia interlitica is one of them, that can survive at 4 degrees, okay? So if there's any, if you don't properly cleanse your venipuncture site during the collection, if there is any type of interference in that closed system during the donor component processing, and then if there's any variance in your storage temperature, that can cause contamination in the product, okay? There's always the fact, you know, we talked about our donor questionnaire and donor acceptance. So we take the donor's temperature, right, to try to see if they might have any infectious disease, but maybe they're asymptomatic during the donor process, all right? And so we don't detect that bacterial contamination. That's one way the unit might be contaminated. Those bacteria that can survive at storage temperatures, that's one way it can get through as well. And then again, some type of system failure where maybe there's a pinhole in the blood collection site or set where the bacteria can enter, any type of testing error, collection was not followed, aseptic technique wasn't followed, and then that storage temperature. Those are all reasons for bacterial contamination. All right, so here's your most common organisms. that can survive at 4 degrees, all right? Yersinia interlitica, sorry, I can't talk, Serratia liquefaciens, Pseudomonas fluorescens, and Listeria. And you guys knew about Listeria, all right? These guys are the most common culprits in refrigerated products. For platelets, all right? Staph species, strep species, bacillus, all right? You guys learned about bacillus. He is a very common contaminant, all right? He's easy growing. Klebsiella, Serratia, E. coli, and Enterobacter. So these are all common platelet contaminants that could be passed on to our recipients, okay? Notice in this platelets some visual clues of contamination. See, and you guys usually know platelets usually have like a fluid substance to them, okay? Look how you kind of have this clotting, this what's the word? Precipitate forming in there, all right? Anytime you see that, I would not recommend that unit for transfusion. Discard it, all right? If it's real cloudy, turbid, now some patients will have turbid plasma depending on their diet and stuff like that. But if it's like real murky and maybe it looks funny, you can discard it, all right? Now that affects your inventory. You might even call the donor center and say, hey, you know what, this unit visual inspection looks a little bit off. I'm discarding it. Can you send me a replacement unit? That way your facility isn't associated with extra costs. So you can work that out with your donor facility. They'll probably do that for you. But just make sure you document that this unit was discarded because of visual inspection. It looks to be contaminated. Okay. So that's for platelets. Red cells. Okay. Red cells is a little bit harder to see any type of bacterial contamination, but you can still do a visual check. I always like to lay my bag flat down on the surface and run my hand over it. All right. I like to see those red cells moving in there. If you happen to see any stringiness, all right, so kind of like little microclots, anything like that, I would definitely discard that unit, okay? And so notice here is a unit after transfusion that had some bacteria in it, and notice how all these clots remain. That bacteria has caused the clotting in that sample, or in the unit, all right? So that's kind of what really hard to see beforehand, but if you do a very good visual inspection, it looks. See all this little area right here? That's what you look for. Again, very difficult to see in red cells. Very easy to overlook. That's why you always want to do a good visual inspection. You could also, it's very hard to detect any type of cell hemolysis in your donor unit if it has been in the refrigerator and some cells have settled out. You might see a little bit of substance on the top. You can try to look at that. To see if you notice any visual hemolysis, but it's very hard to tell in red cells because there's minimal plasma in red cells. All right, any questions? For plasma, if you were looking, plasma is very similar to your platelets, all right? So in perfect world, your plasma should be clear yellow. However, sometimes you will have green. I've had a green plasma unit before, depending on what type of medication your patient's on. But if it's real turbid or clotty looking, precipitate inside it, I would discard it. Okay. Now, plasma has an extra step in it. You thaw that plasma at about 30 degrees in a water bath. All right. So that's another added step for the potential for bacteria. All right. So if that unit is already bacterial contaminated and then you put it at 30, 35 degrees to warm it up, then that bacteria could ultimately thrive as well, all right? And again, especially if there's any type of breakage in the closed system, all right?
Would you look for that for the irradiated products?
Mm-hmm, yeah. So some efforts that are in place to try to reduce bacterial contamination, always try to maintain that closed system, right? During the blood product processing, they're gonna maintain that closed system. Always try to use aseptic technique. Use your sterile docker if you are connecting and disconnecting satellite bags, maybe you're pulling the unit, always try to do aseptic technique. When you're pulling the unit and you're accessing the port, make sure, I should show you guys how you access a port. Maybe I'll do that in lab tomorrow. You have to pull back the units. You actually break the seal. And then there's a little hole in the middle. That's how you access it. And so anything you're going to add to it will have a spike on it. And then you have to add that spike into the unit. So it's very important. Always try not to touch that internal core where access to the unit is. And then your spike is sterilely covered. And as soon as you remove that cover, you don't want to touch it. You don't want to lay it down. All right, so you have to have everything ready. And as soon as you remove that cover, it goes immediately into your bag that you're spiking. All right, that's why pulled products such as cryo, once it's pulled together, is stored at room temperature, only has a 4-hour expiration time. All right, that's why, because it's kept at room temperature and that closed system has been broken. All right. So this is the reason behind all of our expiration times. This is why washed red cells only have expiration of 24 hours, because the port has been accessed, but it's stored at refrigerated temperature. So it's a 24-hour expiration time, okay? All of you guys should know that today, right? Yes. Proper phlebotomy technique, again, making sure during the donor collection process that you use those 2 antiseptics, all right? Something else that has been incorporated into the donor collection process is diversion of the skin plug. Do you guys remember when I showed you the picture of the donor? She had the needle in her arm, she had the unit where the blood was going, but then she also had this little diversion pack where about 10 to 20 mils first being collected went into that diversion pack. And that's just because the skin plug goes in that diversion pack. Could potentially keep that skin plug, which could be contaminated, from going into the donor unit, all right? And then donor health check, so checking their temperature, asking if they're on any antibiotics, how are they feeling, all right? Those are all to try to prevent infected donors from donating. And then a post-donation. So after you donate, maybe the next day you find out that you were septic, you need to let the donor facility know, all right? So there's mechanisms in place. You can contact the donor facility. They'll pull your unit. It won't even go into inventory, all right? Most people, probably the common population, that's why we give them that education material to let them know that they have that option. Most people probably wouldn't think to do that though. Okay, let's talk about another transfusion reaction. Transfusion-related acute lung injury, also referred to as TRALI, okay? And the mechanism behind TRALI is considered a 2-hit process, okay? So usually, number one, the patient has an underlying condition, whether it be, maybe the patient is already septic, maybe they had a trauma, some type of stress on the body, maybe any type of underlying condition that has already stimulated their white blood cells, specifically the neutrophils, which are capable of releasing cytokines. And remember, part of the phagocytosis process is they can adhere to the vessel walls, okay? That's key in TRALI, because those neutrophils, and this happens when those neutrophils are in the microcapillaries of the lung, okay? So what's happening here is these neutrophils are stimulated. They are going to adhere to the capillaries of the lung. And then what's going to happen is the blood product comes along, and maybe the patient has an HLA antibody, which further initiates an immune response. It's going to break those microcapillaries in the lung, therefore introducing those neutrophils into their lung. And that is what's going to cause infiltrate of liquid into their lungs. And it's going to cause them to have a hard time breathing. They're going to have edema around the lung area. And so that's what a TRALI is, okay? That's one reason for the TRALI. It's a double hit, okay? There's another reason that says women who have had multiple pregnancies, okay? And so you guys know one way to build antibodies is through pregnancy. right? So for females that have had multiple pregnancies, they have the potential to have more HLA antibodies, right? So the more HLA antibodies you have, the more of a risk you are for your recipient, right? So oftentimes what donor centers are doing now, they are not accepting females who have had multiple pregnancies as a sole plasma donor, right? Because they have too many HLA antibodies. And you guys remember at the beginning of this lecture, I said that trolley is now one of the leading causes of transfusion reactions in blood bank, all right? Because remember, febrile non-hemolytic used to be, but now we're leuko-reducing products, so that has drastically increased. So when there is a transfusion reaction, trolley is the cause now, right? So here's your symptoms of a trolley, and this is affecting the lungs, the ability for the patient to breathe. So these are life-threatening, all right? Your patient's gonna develop fever, chills, hard time breathing, so tissue hypoxia, shortness of breath. They might even have a bluish coloration, again, because of the inability to breathe, a non-productive cough, bilateral pulmonary edema, all right? That's the swelling in their chest. Their lungs are filling up with fluid, right? That's causing the swelling, okay? That's why it's so hard for them to breathe as well. This is the #1 symptom of trolley. You guys need to know that, all right? Pulmonary edema in both sides of the lungs, okay? And this is usually going to occur, this is an acute, all right? This usually occurs within 6 hours following that transfusion. What we're going to see in blood bank when we do this transfusion reaction, right? The DAT is going to be negative, all right? Because if it's HLA involved, all right, it's not affecting our DAT. So our DAT is going to be negative. There's going to be no visual hemolysis, all right? If your patient, so usually this is going to occur in patients because these are HLA antibodies. So usually you would see this if it is a multiparous female, multiparous meaning that she's had multiple pregnancies, female, and she did donate for plasma, this would be the patient received that plasma product from a multiparous female, all right? So that's why I said most donor centers now aren't accepting multiparous females as plasma donors, right? And that's why, to prevent trolley. So males, you guys are the perfect plasma donor, all right? So they will gladly take your plasma. Females, if you haven't had any pregnancies, they will gladly take your plasma as well, okay? But if you're a female and have had previous, especially multiple pregnancies, they will not let you donate just plasma, all right? Because that's where those HLA antibodies are circulating, okay? Okay, so TACO. TACO is transfusion-associated circulatory overload. Right? This is what happens when, let's say, a patient is transfused a unit of whole blood, which has red cells and plasma, when all they really needed was red cells. Okay, this is what happens, and there's 2 specific populations that are at risk for circulatory overload. #1 are those older patients who are greater than the age of 70, and #2 are neonatal population, all right, so infants. And what happens here is your patient's circulatory system just cannot handle the volume. Okay, so that's why this is not often seen as much, because we are now giving specific component therapy. All right, so you want to make sure before you transfuse a patient with plasma that they actually really do need plasma. All right. Symptoms, it could cause your patient to go into congestive heart failure due to the circulation overload. They're going to have respiratory distress, a dry cough, hard time breathing. Their BNP is going to be elevated, heart failure, like I mentioned, pulmonary edema. So they're going to also have swelling in the chest, severe headache, and peripheral edema as well. So they might have swelling in other parts of the body too, like swelling in their ankles. Because think about what's happening, their circulation is overloaded, so they're going to start retaining fluid, all right? So we will treat with oxygen therapy, and because they're retaining that fluid, diuretics, okay?
The difference in the pulmonary edema for this compared to the last thing would just be that their lungs and this aren't filling up with like.
Right, yes. So let's see if I mentioned it on here. Notice here, your chest x-ray is also included. You will be able to see the infiltrates into the lungs. When a trolley is suspected, you'll see that on the chest x-ray. With the taco, you won't have the infiltrates. The thing with taco is that circulation system, and there's so much volume. The heart is working overtime. That's what's going to cause their shortness of breath and the swelling. Katie.
So trolleys, there's high doses with lower blood pressure.
Mhm.
Be higher blood pressure? It's about more.
I think it would be higher because the heart is like really, yes, it's working hard.
And your blood volume would go up.
Yep, and your total blood volume goes up. Yeah. All right, so does everybody feel comfortable with the difference between trolley and taco? All right, so remember taco is circulatory overload, all right? And like I said, that has really been decreased now with component therapy. And that's why it's very important when your patient only needs oxygen carrying capabilities, maybe we need to raise their hemoglobin up a couple grams, right? So maybe they need 2 units of red cells rather than a unit of whole blood. But like we all know, whole blood is not routinely kept in blood banks anymore. Okay, so that has really reduced the number of taco occurrences. So some measures to prevent transfusion reactions. Pay attention to your storage temperatures, okay? Store red cells at refrigerated temperature 1 to 6. Keep in mind if that product has been outside of refrigerated temperatures for greater than 30 minutes, it needs to be discarded, right? The nursing staff does not understand that, okay? So it's important, they request a unit, it's sent up, and then they say, oh, you know what, the patient decided to go for a CT, he's not in his room right now. If that unit does not come back to blood bank within 30 minutes, and that's a common occurrence, I promise you, you will see that, whether the patient went for a walk with their family member and they're not in their room, or they went for another exam such as CT or anything like that, the nursing, if there's any type of delay and that unit is away from you for 30 minutes, has to be discarded, okay? And also to nursing receive that unit and they say, oh, you know, we're not going to transfuse. We decided this patient doesn't need a transfusion. Okay, so anytime that unit leaves the blood bank and comes back, number one, we're going to check the temperature of that unit. If it's out of range, then it's discarded. If it has been out of blood bank more than 30 minutes, it's discarded. Okay, we don't take any chances. All right. And again, never warm red cells above 37 degrees. Except for the only time you can use this is if it is a approved blood warmer, okay? And then even that temperature must be monitored and it must be calibrated and QC. Okay, so it must be an approved blood warmer. And don't transfuse if the patient identification or your donor unit, if there's any question, don't transfuse. We must investigate any discrepancies and we must resolve any discrepancies as well. And again, never sign out blood by the name only, never sign out blood by the room location, okay? Don't do that at all. And then again, make sure your nursing staff is aware the only thing that you can run with blood is normal saline, okay? 0.85% normal saline or 0.9% normal saline, all right? You'll have nurses call and ask you that, I promise. Yeah.
Really going after nurses again, huh?
I'm just telling you some of my experiences. And then make sure you follow procedures, issuing blood components. Again, 2 people must check that unit. You're checking patient information and that donor unit, performing that visual inspection as well on that unit, okay? And then specimen collection, labeling, testing, especially if you're in a donor center and you're involved in the phlebotomy process or the component preparation process, make sure you follow that aseptic close technique, okay? Okay, so some common types of transfusion reactions that we talked about in this lecture. We talked about febrile non-hemolytic, all right? Remember, those are usually due to HLA antibodies. We can reduce the occurrence of febrile non-hemolytic by leukoreduction. We talked about allergic reactions, both minor and severe. Remember, if it's severe, it's considered an anaphylactic, and those patients either need washed products to get rid of the minute amount of IgA that remains, or IgA deficient plasma, okay? Remember, hemolytic transfusion reactions, all right? So this will be a febrile hemolytic transfusion reaction. This is where your DAT is positive, okay? And that's usually seen if a wrong ABO is given. That is the most severe, can ultimately result in death. And then bacterial contamination is severe as well if it's not treated, okay? Usually once we identify that it's bacterial, then the patient started on antibiotics, okay? And then again, all those mechanisms in place that we talked about to prevent these reactions. All right, anybody have any questions about some of the reactions we talked about so far?